About to start, so I'd like to ask the people who are sitting at the far back to please join us in front so that we can start. Thank you. We're going to have a panel on health commodities towards the hard-to-reach population. We have our panelists with us today, and I would like to right now invite them to join the panel so that we can start with the discussions. I would like to invite Ipsf Wc, the country director of Chemonics, to join us. I would like to call Dr. Kenshi to please join the panel. And I would like to call Dr. Karel to please join the panel. Thank you so much for accepting our invitation. We are very excited to hear from you and to drive this discussion. I would like to start by calling upon Ines to start with the keynote speech. Thank you.
Good afternoon, everyone. Right, so just to introduce a little bit this panel, I think the question today for us is how the health commodity supply chain is important to reach universal health coverage. So one of the big challenges impacting patient accessing complete health care is an availability and stock out of health commodity. Health commodity supply chain management in the health sector has been neglected in least developed country and has affected the cost and accessibility to healthcare of patient and community. In many countries, supply systems are the recipient of significant government and partner investment, and because of this investment, significant achievements are made on the maturity of the supply chain system as well as its performance. In Rwanda, for example, as a country where I operate, a recent national supply chain assessment found that supply chain systems are in place across all levels, means at the central, district, and peripheral level. We have functions such as procurement, management of logistic data, and storage and distribution that are covered. Forecasting and supply planning systems are well established as well. Products are selected through existing essential medicine list. Quantification and supply planning are coordinated at central level through coordinating procurement and distribution mechanisms for all program area and involve the use of national logistic consumption data on national target as well, and multi-stakeholder process to ensure that the process and plan are harmonized and aligned. We also have upgrade procurement systems that are in place in the public sector with automation of key procurement process functions. Storage and capacity and management practice at central level are also mature. We have significant and important investment that has been made to upgrade storage capacity and facility. Of course, staff, human resources are in place. Staff, especially at lower level of the supply chain, are well trained and are all motivated to operate the system. Stock out rates were found to be quite low, and when they occur, they do not last long. And this is attributable to the positive response of emergency order system, which accounted for almost a quarter of order placed. To reflect more and improve pharmaceutical sector in Rwanda through few indicators, 93% of children from 12 to 23 months are fully immunized. Around 90% of population diagnosed with HIV infection receive sustained antiretroviral therapy. 84% of tuberculosis cases have treatment coverage. 87% of health facilities have less than 5% of medical products stock out. But of course, over time, with the emergence of non-communicable diseases and the increasing of volume and variety of products, health commodity supply chain systems have been showing challenges to provide faster response to the system and to the need of patients. And I hope this panel will have a very fruitful discussion. Thank you.
Thank you so much, Ines, for giving us an overview and a broader picture of how the supply chain of Rwanda is currently. And right now, I would like to call on Karel to give his presentation on an innovation that the project they've been carrying out in Congo of using motorbikes to solve supply chain challenges. Mr. Karel, please welcome.
It will be displayed, the picture. I come a bit nearer to you, feel more comfortable. Good afternoon. I know now at this moment why this session is called for the hard to reach people, because to get everyone in this room it was very hard. But for the ones who came, congratulations and thank you. I hope we have a good session. Unfortunately, I have to leave because my plane is leaving, and I cannot stay for the panel, unfortunately. But I would like to share at least a story, because when they ask people, the organizers, to talk about universal healthcare in the context of how to reach people, I had to think about, it's not really linked with the supply chain, though indirectly, because well, I didn't know it was going to be specifically on supply chain, but I think it's linked nevertheless. So I was thinking of a place called Subangi, which is in the northwest of DRC at the equator region, and I would like to share a story about it. In this region in Congo, it's really hard to reach. You can only reach it by plane, and within the region, circulating with vehicles is, especially in the rain season, is very hard. So, and you have in the zones we support together with the Ministry of Health, like Bwamanda, Bujela, a maternal mortality of more than 600 per 100,000. And perinatal mortality of 93 per 1,000. So there's a huge challenge there. And I would like to say, okay, looking through the lens of universal healthcare, what can you do in such a region, such a region to improve actually what is called in universal healthcare? That's a definition to ensure access for all the people, whether it be preventive, promotive, curative or rehabilitative healthcare, and obtain services of good quality without financial hardship to pay for them. That's actually WHO definitions. Well, actually, I show my hand. There are 5 components. If we talk about access to quality care, 5 essential components which are very important, the 5 A's. And one of them is the availability of services, because services have to be, health services have to be available, but it's not because they're available that they are also accessible. And it's not because you have services and they're accessible that they really are acceptable, meaning of good quality. They should also be affordable, that people can afford to pay. And 5, they should be accommodative, meaning that they are flexible, people-centered, and responsive to the needs of the people. So, looking at that lens of the 5 A's, we started to work, and one of the strategies which was developed at the level of the districts, the health districts, was to initiate. Well, there's the availability of services, of course, which means ensuring that equipment, but also drugs, but also the national drug system through the FEDECAM and not only the supply chain with the depot pharmaceutique in the region, but also the quality, because as you know, quality is very important. You can have drugs, but what is the quality? And for that, FEDECAM is part, as a national distributive center, is part of the network QAMIT, an international network, who looks also at quality of procurement according to pre-qualification standards. So those requirements are basic, to have this availability of material resources, of health commodities, of staff, who is trained at the hospitals and at the health centers. Of course, because you have to need this availability. So that was worked on, but a specific strategy which was developed, well, it's gone now, but you saw a motorcycle, is specifically on the accessibility. Because you have to imagine we are in districts which are huge. They are about, in a diameter, 100 or 150 kilometers. You have 20 health centers, you have a hospital. The ambulance of the hospital cannot reach most health centers. A lot of health centers don't have access of radio connection. So if people have to come to the hospital, for example, for an emergency obstetric care or for a very, very sick child or whatever emergency, they have to sometimes walk up to 80 kilometers or more. So the strategy which was developed was to put in, because we didn't have the money to put in all health centers, but in selected health centers, 5 per zone, and in 23 ambulances in 4 districts, to put moto ambulances. No, we have to go back actually, because, yeah. And you see those are special motorcycles, because the ambulance cannot reach. So if you want to pass in the difficult areas, you have to have motorcycles which can pass. And what was done, there was a kind of system mounted on it. You see a kind of seat on which the patient is put and transported. It's not as comfortable as an ambulance, but at least it allows people to walk only for 5 to 10 minutes maximum and to reach to the hospital. So a whole system was developed of, there were also drivers which were trained a bit in safe driving and things like that, which transport the people to the hospital. To private sector ambulances, there were people have private ambulances or motorcycles who were willing, just paying the fuel was necessary, to transport patients because they saw it was really life-saving. But of course, motor ambulances cannot solve the problem alone. As I said, there were 5 A's. You can have services, you can have the access, physical access, improved through this system, but there's also the financial affordability. Now, what was done was to work with a flat rate system, so that people had to pay for a package of care, not for every different sickness and paying separately for the drugs. No, there was a package that for all, for a certain number of diseases, there was really, or for the whole basic package actually, it was a flat rate, so that people know in advance, if I go to the hospital, if I have to have a treatment, or if I have to have a cesarean section, this is the price I'm going to pay, and it's not going to be more. Of course, you have to monitor it, but it gives a clear message to the people, that is the price you're going to pay. So it helps people deciding. So this was installed, and some of the people, because we are in an area which was previously called CDI Boamanda, which was an integrated project where people sold their goods, their agricultural products, and exchange were a member of an insurance, a mutuelle. There were about 15, 20 years ago, about 200,000 people affiliated to that system. Now, of course, it has, with the problems, actually, the challenge, it has gone down a bit, but still 67% of the farmers are affiliated. So even if it's not ideal and it's not a comprehensive health insurance, national health insurance system, it helps or this affordability. So that's a third A. Then the fourth one was on acceptability of services, and that has to do with quality. Because it's not because you have material in your hospitals that everything is okay. You need to have a kind also of supportive supervision, a kind of quality system which was developed in the hospital. I don't go further in details because time is not with us. And accommodation, it's linked to that quality, the responsiveness to the people. So we have the 5 A's, and what was seen, and it cannot only be attributed, of course, we have to be very critical about results always, because there's always a context which is influencing those. But at least we saw in over a period of 2 years a decrease from 600,000 to 600,000 to 200,000 on average, 200 per 100,000 maternal deaths, which is a decrease by a third. And also a decrease of the perinatal mortality from 93 to 57 per thousand, which is actually substantial. And the increase of referral was 3 times, thanks to these motorcycles. Okay, this is the story. I'm just going to share 4 lessons with you, and then I'm finished. The first one is universal health coverage can be done in any situation. It's not that you say we have to have all the conditions to start working it, because universal health coverage is a direction, it's not a destination. So even in hard-to-reach conditions, you can work along these principles and progress gradually towards them, and you work with a consistent vision. This is a first important message. A second important message, and this is the second picture I would like to show, is that you cannot have results if you focus only on one particular activities. If we would have only the system of ambulances, of motor ambulances, we won't have any results because you just have a means of transport. But what happens is that you have to also, yes, the next slide, you have to also have the whole chain. You have to have the chain of the hospital quality, of the availability of drugs. So you're working on systems. A systemic, comprehensive approach is important. This is a second message I want to convey. A third one is actually on the aspect of learning. Okay, well, here you see it's a picture to illustrate. It's not by program on one particular item, like providing motor ambulances, that you will have. You should have the reality is more complex. You should be able to work on more determinants at the same time. That can be done with others, but it's important that you work on the several conditions at the same time. Yes, next slide, please. The third slide is on learning, actually. Yes, I show this picture because you see how learning takes place in reality. You implement a system like motor ambulances, but you improve on the system. Okay, yes. Okay, you hear me? Okay, fine. So those motor ambulances you put them in practice, but the system has been refined because we saw that actually there were also people dying on the way. So the drivers were trained to give first care, to have also attention to the patients. The seats were improved over time because this is the last version, for version 3.0. There's also feedback mechanisms from patients giving feedback on the system. So actually, if you initiate a strategy, for example, in your district or whatever your position is, you take a decision, even if you're not sure it's going to work, but you monitor and you continuously refine the thing based on practice. And that is what's happening with the bicycle of history. Over 2 centuries ago, we had the bicycle, but through practice, it continuously improved, and the evolution is still not finished. So learning, stimulate learning in teams is a third message which is very important to improve quality. And lastly is, because the question might come, is about sustainability of all this. Of course, this is a big challenge in Congo, and this is still a big challenge. I won't deny this. But there is a difference between sustainability and sustained. A project in collaboration with the Ministry of Health, but a project can develop strategies which could be shown to be cost effective, which are adapted to the local reality. And they have the potential of being sustained. But it's not that they are sustained per se. There has to be always, and that is the responsibility on the government side, to take up the responsibility to sustain it. And this is a choice every country makes. You can show something innovative, something which might work, but it's always up to the country to make the decisions. And that is what we have done, or try to do, doing now actually in Congo with those motor ambulances, is to the governor, because as you know, maybe in Congo there is a kind of provincial division there's now ministries of health in each province. There's been a kind of decentralization process. So our point of reference in the province, in the Equator province, is now the governor and the Ministry of Health there. We use this opportunity of the motor ambulances and the whole system for reducing, with better results, to encourage making an advocacy at the level of the governor to invest in health, because there is a very low degree of investment, public investment in the health system. So instead of asking just a general contribution to a budget, through these concrete examples, illustrated, documented, this gives an opportunity to demonstrate in a concrete way system and raise the amount of public investment in the health system. So that is what we try, but of course this remains a big challenge. I fully acknowledge this. So, well, this was a talk about not directly the supply chain, but I think the wider theme of this conference is universal health coverage. So that's why I would love to share this story with you. Unfortunately, I have to catch my plane, so I won't stay for the whole panel. But I hope you have still a nice discussion further. Thank you.
Thank you so much, Dr. Karel, for... I was saying thank you so much for giving us this presentation. It was informative enough, and it was good for us to learn about the initiative and the project that you carried out in Congo. And my one keynote things I got from this presentation is that the universal health coverage is possible, and that the universal health coverage is a direction, not a destination, and that in any settings, health systems could come up with initiatives and strategies like this to allow access to the population that live in remote areas. So that was a very insightful presentation. My question to you is, I will ask one question and let the audience ask one question, and would let you leave. Yeah, so my question to you is, how could we strengthen the health systems of our countries to be able to come up with strategies like this in case of emergencies, or in countries with really remote areas like Congo and other different countries, to be able to have the strategies like this in place to play in case of issues in the healthcare systems, and to enable the population to access the care they need. How do you think we could strengthen that?
Okay. Maybe, I don't know if is it working? Okay, yeah, thank you. Well, I will reply in a very generic way, because you ask countries in plural. If you talk about health system strengthening, and as as I'm part of a bilateral agency, our entry point is always the Ministry of Health to start with. We try to have a kind of approach where we always start from the national policies. I think it's important that as a development partner you don't come with your own strategies, but there isn't in most of the countries very well designed national policies and strategies, but the big challenge is to the implementation of those. So the first strategy is to align with the national strategies. The second strategy in health system strengthening is not remaining at the level of the policy, but always also be active at the operational level, because it's there that you see how strategies are implemented. Whether it's drugs, you can have a nice supply chain policy, but you have to see really at the field what is happening, and what are the challenges, and working on them. And so that's the second strategy, be also at the operational level, not only at the strategic level. And then, as I mentioned, the learning mode, be in the learning mode, is try to, from the field level, try to distill document the challenges which are there, also the good practices, and try to get back to the decision-making level. Could be at the province, could be at the, or could be at the district, could be at the province, could be at the central level. So to try to take the lessons from there and refine the policy, so that as the bicycles, you get continuously improved national strategies, and you strive towards excellence. So it's a kind of learning cycle you have within the health sector, starting from the national level, going to the field, taking the lessons and feeding it back. Well, it's very generic and it has a lot of challenges in practice, but this is the vision which we try to do, and not working in parallel. And I think Rwanda is a very good example of because with a strong leadership, everything is integrated starting from the national policies. Yeah. But it's also a challenge to see how it works on the field.
Right. I'll take one question for the audience, and then we'll move on with the discussions. One question from the audience. Right.
My name is Lutz Heide from Tübingen University, Germany. Has Ministry of Health started to copy the idea and also got motorcycle ambulances?
Yes, if we this initiative was copied in other districts, not at the full scale yet, but in the Kwilu, in the Bandundu region, more south. It was also implemented in a few districts. But of course, the aim is to take the lessons from there and to scale it up at a national level. This is the purpose. But there's a kind of horizontal scaling up, I would say, where districts meet and then they say, oh, this is a nice idea. So you have this type of spreading, but there should also be at a vertical level where the decision-making level is taking it up. But what we see within the province already is that districts which were not supported started with private ambulances, and because now I think about 30% of the patients are transported through the private ambulance system. Of course, we have to monitor what is the price. There is a small fee for the fuel which is asked, and we should monitor how sustainable this is. But there is a demand, and this is encouraging. But it's a good question. So it's right. Work in progress.
Yeah, thank you so much, Dr. Karel, for joining us today.
Okay, thank you.
And thank you for a very informative and great presentation. We thank you so much.
Okay, thank you. Sorry for not able to be staying, but I hope you have a good discussion further. Thank you very much for my co-panelists.
Thank you.
Bye-bye.
Yeah.
Thank you.
So we're going to move on with digging deep into the topic. I would like to bring in Dr. Kenshi. Dr. Kenshi is a physician by training with an MBA and a Master of Public Health from University of Liverpool. She's supported the Rwanda Social Security Board as a technical advisor and currently serves as the regional technical advisor for Clinton Health Access Initiative. Thank you for joining us today. My question to you right now is, the medicine does not reach the health facilities where people collect it, and nearly 50% of the people lack access to critical medicines. But in contrast, products like, for instance, Coca-Cola and are available almost everywhere in the continent. And I would like to ask you, what do you think we're missing? What are the challenges you're facing in the supply chain of the medical products? And like, could you, from your experience, from where you've been working, what have you seen are the challenges that are preventing us to reaching all those places that the other fields and the other companies are actually trying to reach?
So that's a great way to ask that question, actually, the concept of Coca-Cola. And that's actually perhaps something to throw open to the supply chain specialists. How is Coca-Cola able to do this? And somehow we still have challenges. And so I'm going to sort of talk through some of the experiences that we have had that kind of explain the problems with the supply chain that ultimately affect our capability of being able to leapfrog universal health coverage. I think Ines and Carol sort of touched on the fact that this whole conversation really is about how can the supply chain actually help us reach universal health coverage. And I think it starts from first an understanding that for us to be able to provide life-saving health commodities to underserved population, hard-to-reach population, vulnerable population, we really need to understand the challenges, the problems with the supply chain, especially the in-country supply chain. And that's because before you come in-country, there are a couple of processes, whether it's how you're getting your raw materials, how you're manufacturing. And I'm using like Rwanda as a case study because we don't do too much manufacturing here. So the problem starts all the way from the policy. And so it's either the presence of a policy or the lack of a policy. And so the issues with universal health coverage, when people are able to access what they need at the right quality that they need it when they need it, speaks to, am I having it? Am I able to afford it? And am I entering sort of like, am I experiencing financial hardship in being able to access that? And so with a policy in place, policies to maybe safeguard quality, maybe to safeguard how we're procuring, it could do a couple of things. First of all, strengthen the process of procurement, but then again, it could also introduce delays in procurement. It could sort of restrict even the specific medicines that we can get. We can have policies in place that essentially speak to getting in medicines that are not necessarily aligned with the EML, the essential medicines list. And so we're procuring medicines that are not really priority. And so the people who really need these medicines go to the health facilities and they don't have the right medicine that they need. And then it could be the lack of a policy, actually. So for instance, until very recently, we didn't have a pricing policy. And so that means that when people have to procure, when the central medical store has to procure, it's almost like a thumb suck. How do we determine, what the pricing would be? Because there's really nothing to guide. So that's on the policy part. And then if we move from the policy part now to procurement, the challenges also are, first of all, maybe sometimes not even having the right capacity for people to actually understand the procurement lead times. Oh, and actually before I get to procurement, first will be the quantification, because you need to figure out how much you need. And so do we have systems in place to actually understand what the needs are? Typically, for most of the vertical programs, you would find that they're well quantified. For malaria, they can tell you almost like to the last tablet how much they need, the number of patients that they expect to be able to treat. Hepatitis, all the other vertical programs, they can tell you that. But when it comes to essential medicines, it's almost like what we're trying to say is, okay, last month, people asked for 5,000 tablets, so let's just get that. But the question is, of the 5,000 tablets that we got, are we capturing the people that we didn't serve, the people who came in, who needed that medicine that we weren't able to supply? Are we capturing the demand outside also of the public sector? So these are some of the gaps. And so the question is, do we have data that speaks to what the demand really is? Is this data accessible? Is this data of the right quality that can actually help us to determine how much we actually need to procure? So that's on the quantification part. And of course, the capacity, people to really understand how to quantify, and the tools, because you can't depend right now on manual systems to be able to do that. Are there real-time tools that actually capture what the demand is and perhaps what even the missed demand is? And then we now move on to procurement. And one of the key issues with procurement, like I mentioned earlier, was whether you even have a policy that guides you in the procurement. And then it also speaks to whether the people who actually do the procurement understand that they have some tools at their disposal. For instance, how do we have agreements or contracts or MOUs with the people who supply us the medicines? Do we apply some flexibility, understanding that we can actually have some framework contracts that kind of lock down specific prices, or even speak to prices based on specific volume, so almost like a sliding scale? Are we aware of that? Are we practicing that? Then from procurement, we kind of move down into distribution, into warehousing. How do we store these things? Where do we store them? Do we understand the people who manage this? Do we understand the whole concept of first to expire, first out? Do we understand the concept of maintaining a cold chain? Because what would be really sad would be that we're now called upon, the supply chain specialists are called upon to deliver these particular medicines, and then we check in the central store and everything is expired. And because everything is expired, of course, it has a boomerang effect, and everybody says, oh, we shouldn't procure so much. But was that really the problem? Was it that we procured a lot, or we just didn't manage it properly? And then it's also about where the warehouses are even located. Sometimes they're located more out of administrative convenience than functional convenience. It should really be close to the service delivery points. And then we talk about distribution. Do we have reliable, available, and good quality transportation systems that mean that this medicines or whatever, these health commodities are available and can be transported wherever they are needed at the time that they are needed? Do we have the right facilities in them to actually store these medicines the way they need to be stored, so that they can actually provide the right value, to the patients who ultimately take them? And the last part of that whole value chain will now be the service delivery point. So you have the health facilities that are also supposed to dispense these medicines. But the health workers have so much, they have so many other tasks that they're dealing with. And so having to put together reports or to run trends to understand whether the demand is this high or this low, or to be able to speak to a trend, a peak, nobody has time for that, because there are other things that they're doing. And there's really very little supervision. And then the next question, which really speaks to the heart of this topic, is also, how do the hard-to-reach population access the service delivery point? How do they get to them? Are they located to sort of make sure that these hard-to-reach populations are well served? So these are just some of the thematic areas that the whole concept of supply chain, these are some of the thematic areas that you can actually look at the relationship between supply chain and the achievement of universal health coverage, because the whole idea of universal health coverage is access. It's access first and foremost, before you even now talk about, the good quality healthcare, because if you don't have access to it, then we can't talk about, how good that quality is. I do understand, of course, that these areas do not stand alone, and so one area kind of, would be interdependent, interrelated with another area, but these are some of the key issues that affect the supply chain, and ultimately, there are two key things that result from this. One, that people are unable to afford these medicines. And the big deal about this is the fact that even when people have community-based health insurance or any other kind of health insurance, typically for a lot of the care that you get, there is some level of copay. And so when we're not really maximizing how we're buying, for instance, one of the key problems, again, especially with procurement, is us always just looking at the public sector and not looking at the entire market, which sort of gives us bargaining power when we're buying. And so if we're not maximizing all of that, ultimately, the final price of the medicines or of the health commodity becomes very expensive. Even if we look at it like somebody else bears that cost, maybe it's a health insurance scheme, ultimately the final user also bears a part of that because they have to pay a percentage. And the higher the cost of these health commodities, the higher that these people have to pay. So it's about the high cost of the medicines, but then it's also about stockouts. We've talked about expired medicines. And so when people go and they can't access the medicines that they need, then they go home without what they need, or they have to dig deeper into their pockets to go and buy from some other alternative sources. So ultimately, we have two key issues that we keep grappling with in health financing, which is stockouts of these essential commodities and also the high costs, meaning that for the health insurance, you're having to pay more, and then also for the members, the ordinary Rwandan, they're either being pushed further into impoverishment or they actually suffer catastrophic health expenditure in trying to access these medicines. Thank you.
Right. Thank you so much. A big round of applause. Thank you so much for an extensive description of the problematic areas you have in supply chain and trying to help us really understand the gaps. I would like now to bring in Ines to talk more about how could we create reliable and sustainable supply chain management systems to be able to solve those challenges. And I would like you to touch on the systems that are already in place and the projects that are being implemented to be able to fix those gaps, starting from the very first step, the policy line, from the quantification all the way through distribution.
Okay. Thank you, Christelle. And yeah, again, I'll start with policy. At the policy level and at all the level, we were to add today as a Rwanda government and also a developing partner. So the country has put a lot of investment into have a strategic document that also govern the supply chain system. So based on that, and I think that everyone operating in the supply chain system, whether it's at central level, the central medical store, at the district level where we have district pharmacy and the health facility, they really depend on this policy. So of course, we touch about pricing policy that regulate the price, so this is new, and we are very happy to support the government into that, so that we can have product affordable to the patients. We also have procurement policy. The central medical store, they have an e-procurement system, where they have a automate system, and they can do procurement efficiently through that. So touching the system as well, so they have the country has well-established system. We have district pharmacy that, procure their drug to the central medical store and they deliver to the health facility. So this is done pretty much well, and it's done. They have a distribution calendar that they can, implement and make sure the patient and the health facility get the product on time. I want also to touch a little bit on system investment that the government of Rwanda has made. They've invested a lot over the past year in an electronic logistic management information system. We've touched a little bit about data. Data is important for us to get to universal health coverage. For the health facility to get, and for you to know the demand, you need the data. So there's been quite a lot of investment by the Ministry of Health into this system. They've been training and establishing and putting this system in place in all the existing health facility in the country. So now we have supply chain officer, like mentioned, Dr. Ketchu, that can, operate use this system to be able to import their consumption data and also be able to do requisition and order through the district and the central level. So this has been a very huge investment, and we have seen, of course, we still have challenge around essential medicine, but for vertical program, we are able to have all the consumption data through the system. And actually at the central level, they can type into that system and be able to resupply easily and get the product on time. In terms of system also, we have what we call, what the Ministry of Health has put in place. Over the 10 years, I think we had different vertical program, and each of the program were procuring independently. They were not consulting themselves, and that's led to overstock, sometimes stock out, and expiries of commodity. And so the Ministry of Health decided to put all the program, all the donors together and say, let's do quantification together, right? Let's plan together, let's procure together, and let's plan distribution through the very existing mechanism. So this is a well-functioning mechanism where you have the Ministry of Health pulling different donors together. Recently, we've included as well essential medicine so that we can also know and define what is the demand, why do we still have challenge getting enough health commodity, health essential medicine. So this is quietly operating well, where quantification is done. The data I use, pulling the data from the electronic logistic management system, pulling morbidity data from the National Disease Program, and this is discussed in a forum, and they come up with the estimation, and procurement is done in a coordinated way. So this is really a success for the government of Rwanda, and we were able through that to at least avoid stock out and plan for the supply and the shipment. And there's quite quarterly review that is done in that way between the Ministry of Health and existing partner. So again, staff, I've touched a little bit about staff. Staff, of course, you can't implement a good supply chain system if you don't have staff. So you have to invest. At the Ministry of Health level, there's quite a number of initiatives that is done around professionalization of pharmacy. We are in constant discussion with the National Pharmacy Council, the School of Supply Chain Excellence, School of Excellence, as well as the University of Rwanda, are we really giving the teaching that is needed to run supply chain, right? So we're looking at the labor profile. We are looking at the workforce there. How can we tackle into that as a Ministry of Health to be able to support and revise and revamp our policy and our existing system there. So this is something that is done by the Ministry of Health as they look at as the pharmacy sector is growing and is keeping constantly changing, that we need more and more supply chain experts to be able to deal. So at the health facility, you'll find that we have nurses that manage the pharmacy, but they lack the skill, to do proper inventory management. So as a developing partner working with Chemonix, we support a lot the Ministry of Health to do on-the-job training. But this is really out of the training that is provided at the university, or at the, any school, health school institute, but this is really on the job. How do you fill the stocker? How do you, record consumption into the ELMIS, the existing, the electronic existing logistic management information system? So there's also supervision, support. It's more supportive supervision that is provided through all health facility. And this supervision touch performance. we look at key performance indicator. How can we help those health facility or those store manager, let me call them store manager, to be able to run the inventory, to be able to know what is the demand there, to be able to plan for what they need for the patient within the catchment area. So there's quite a number at each level of the supply chain that need to be touched for you to, you can have the resources, of course, you can buy commodity, but if you don't invest in the system and the staff, and you can, I mean, it's very difficult for your product to get to the patient. Right.
Thank you so much for the insights. It's good to, of course, hear about all the work that is being done, but we're not yet there. We still have a long journey. We still have a long way to go to be able to reach at a level where every patient is accessing healthcare. I would like to ask you, it's my last question, and then I give the floor to the audience. What are the cutting-edge solutions in order to maximize that you think we can put in place in order to maximize the availability and affordability of high-quality medical products? In terms of innovation, we can bring in innovation or technology or any other way. What are the solutions that you think would help us get there?
Of course, we cannot run paper-based. It's very difficult as we have quite a number of products. We have new disease area that come as a merging interest for the Ministry of Health and any government. So we need to move to automation, right? Automation for procurement, automation for recording consumptions, and even beyond that, how do we match, and that is at the insurance level, how do we match the patient clinical record with the health commodity that is delivered into our health system. So this is really something that is still problematic at any country. How do you make sure that what a patient has received as a clinical diagnosis really match with the commodity and the product that the patient received? So we really need to invest, of course. It's quite expensive for some country, but we need to look at sustainable system and investment to make it happen.
Thank you very much. Do we have questions from the audience? We are left with 10 minutes. We can take a couple questions, and thank you so much. Can you pass the mic? We have 3 people there and 2 people at this side.
Hi, my name is Pierre from France. I've got some questions about humanitarian supply chain in some areas. So the list of essential medicines was updated like 2 weeks ago, I think, from the WHO. But don't you think that all the first needs are different in each country? So we could have an essential medicine list divided by region, maybe. And the second question is about how to procure medicine. So in 2011, WHO recommended to use guidelines written by USAID, if I remember. And and I was wondering that I think it needs so much updates. So what is your advice to have do you advise to use local medicine or international help in supply chain regarding humanitarian missions? Thank you. If you
Please. Right.
Okay, the second question was about how to procure medicine. So WHO recommend to use some guidelines from the USAID, but nobody uses those guidelines because there's like NGOs are always lost and thanks, and they are always looking for a new way to get medicines. For example, I know that the Japanese Red Cross is working with Japanese medicines and not with the local medicines used in Bangladesh. So for you, what is the best thing to do, using local medicines or international medicine in humanitarian?
Thank you so much.
More questions and then we will answer them.
Correct.
Okay, good, perfect.
Yes, please go ahead.
I'm Rian from Austria. My question is, you have an idea for a policy and you want to implement it, but there's like a pushback because of lobbying from other industries or for other reasons that I'm not aware of. What would your strategic plan be to still be able to get that policy working in your country? Thank you.
Thank you. Thank you, panelists. I'm Alison from Singapore. So my question is, so the start of this panel, we mentioned that we compare the medication to Coca-Cola, right? So Coca-Cola is a private industry, and that's why the supply chain is managed by the company. But then for this talk, we focus on policies, and that is government's effort in supplying. So my question is the role of supply chain more towards government effort, or does it actually depend on pharmaceutical companies? Because as I interned in Johnson & Johnson, so I was aware that supply chain is actually part of our profile as well. So I'm just curious as to what's the role of supply chain in general, like how can government and pharmaceutical companies come together instead of just relying on policies, and what are the challenges in this aspect? Thank you.
We have a question right there.
Thank you. My name is Samgelo Dlamini from South Africa. I noticed that you mentioned a lot, Doctor, about policy and also about the cost of medication, especially to the patient. You also mentioned a lot about demand and availability of data. But the question that I have is, wouldn't it be another actually approach in terms of looking at the support that the pharmaceutical companies have in terms of the production of this medication? Because we look at situations, especially in the outskirts or in the rural communities, whereby you get out of stock situations, not really because the supply is not adequate, but just because the drug is not there. Furthermore, in terms of the data, research and development, especially in the African region, has not really been enforced much in such a way that we have a lot of situations whereby the drug is not available, especially for the less prevalent diseases that affect maybe a minority, which will then lead to a situation whereby we state that there is no stock or we don't have medication, yet the drug is just not there. So the question that I'm actually having is, what exactly can we do, or what would you propose in terms of uplifting the pharmaceutical industry, especially the research and development and the manufacture of the drugs, so that we can address this supply and demand issue from all spheres, rather than looking at how much does the drug cost for the patient. Let us also look whether is the drug even there, does it even exist, or we have to ship it from China, yet we need it in the USA. Then, yeah, that will actually increase the cost dramatically. So I think we should also look at that, and please give your approach on that regard. Thank you.
Thank you so much. I think these are the questions we had.
I can start and take few. There was a question from France around essential medicine list that was developed by the WHO, and how is it applied to country, if I get it right. So I will again give the example of how does country define their list, and particularly the example of Rwanda. So I think country first should define what is the primary healthcare package, and based on that, they will have to define the list. So in Rwanda, there's been a policy in place that is defining, what is actually the package that is provided at each of the level of the health sector. And then based on that, the Ministry of Health, with the medical doctor and physician define, the list. This list actually is reviewed every 2 years, because every 2 years, as you're sure, the package and the need and the demand change in the health sector. So this is pretty much the example on Rwanda, and I'm sure many African countries does the same. So, and of course, this essential medicine list that is applied at the country is referring to the WHO one, right? I can take, so there was a question around how can government and pharmaceutical company collaborate together and not rely on policy, and I think that was a question from Australia. Of course, policy, I think any Ministry of Health will have to have policy to define the health sector. So the policy actually is the backbone, to secure the health, how the health sector and, the pharmaceutical sector and supply chain system will have to operate. But of course, on the side, the government also have partnership with private sector, with private company, when they look at, let's say, how they can partner to be able to address specific diseases. So there's ongoing partnership that the government of Rwanda is looking with Abbott to say, how do we provide viral loads testing at the cheapest price to our patients for HIV treatment. So there's different partnership that exists at country level also that is directly government with a private company. But of course, those policy will set the tone for how this private company will also operate in the country. So any private company who comes in the country, they have to buy into that policy, right? So we have in country the Food and Drug Authority that also help, set and regulate through this different policy. So any product that comes in country have to be registered, and they have to apply a certain number of criteria before they can even be administered to patients. So this is what I can say, how government collaborates with pharmaceutical company and also make sure that the policy can really define the way they operate together. Yes, so I think there were a question from South Africa that was addressed to, I will leave that to Dr. Ken, then I can complete after that. So I think those are the questions I can take.
Great. Okay, really great questions. I think I'll touch a bit on, I'll start again from the essential medicine list. In a perfect world, the essential medicine list speaks to the priority healthcare needs of that country. The only way that you determine what should be on your essential medicine list is that you understand what your healthcare priorities are. Those healthcare priorities are captured in your standard treatment guideline, captured in your benefit package, and ultimately percolate down into the essential medicine list. So the essential medicine list does not exist in a vacuum. It's context-based for every country. And so WHO would have a list, but for each country, based on this process that I've talked about, which is about what are your healthcare priorities. So the EML, the essential medicine list in Rwanda, would definitely be different from my home country in Nigeria, because the healthcare priorities in Nigeria are not necessarily the same here. So that's how you define it. And so when there are updates, it's important that countries take a look to see what is available, but each country has to define its own. And then you now also talked about, should countries focus on internally produced medicines, or should they use foreign medicines? What is better? So again, I keep talking about a perfect world, and it's important to note that we don't live in a perfect world. So when we talk about what a perfect world gives you, then for each country, again, context-based, context-specific, you've got to find out what works in your own different country. So in a perfect world, each country would be able to produce the medicines that they need to sort out their healthcare issues. And you know what that does? It takes off all those additional costs for freight, for taxes, excise duties, and all of that. And so, and even in terms of distance between the manufacturer and the end user, it's also closer. So that's what would happen in a perfect world. Unfortunately, it doesn't happen that way. And so if you don't have manufacturers in country where you can source your medicines, you have to source them outside. And the question would now be, how do you figure out what works best? So in a place where we have a pricing policy, typically one of the pricing policies would be benchmarking. So when you're benchmarking prices, but you're also benchmarking the specific medicines, the specific products that are available. So you're looking at your neighboring countries, you're looking at your, depending on how you rate yourself on a peer group, and you're finding out what are they using. You're also looking internally, if you're doing internal referencing, again, another pricing policy, to ask yourself, what are the medicines we have been using here that are useful, whether they're locally made or foreign manufactured, what makes sense to bring in. So there are a couple of different conversations that go into that. Should we be procuring foreign medicines or procuring internally? But like I said, in a perfect world, it would be great to manufacture internally and then procure internally. However, we don't have all of those conditions met at every time. And I think Ines really spoke to the policy issue. Like, policy is almost like, we need to have laws that guide this thing, because if there is none, then it's anarchy. I think the question should be, how do we understand better the bureaucracies within the system? So if we have a policy, the policy in and of itself should not constitute a bottleneck to the process. So the question should be, even when we need to have policies, when government needs to work together with private sector, when government needs to work together with other actors, how do we make sure that these policies do not constitute a bottleneck and we're able to, for instance, a procurement policy, how do we make sure that the procurement policy doesn't mean that I need to have, when I make a procurement or when I make an order, I don't get it until 1 year. I mean, that doesn't make sense, because ultimately what happens is that you have to do a lot of emergency procurement, and of course emergency procurement come with more costs, and then even in the interim you have a lot of stockouts, and ultimately what that means is that patients are not getting the care that they need. That means that UHC is still a mirage. Then there was the question on the last question. Let me just speak to the last question from South Africa. What are my thoughts on how we can ensure that the drugs are available? What are my thoughts on improving research and development in the continent? Because there are so many factors, if I heard you right, that affect drug availability. Absolutely. Absolutely. And I think I tried to go into it when I first spoke by saying it starts all the way from policy down to actually the service delivery point. And like I've just mentioned, in a perfect world, and that would be, what I would prefer, we would invest money in R&D and do it locally. The medicines are available here. If you need it, it's almost like, okay, let's just go talk to Buffmer, okay, whoever, needs to produce that. Life is a lot easier, and actually it also affects costs. Forgive my focus on cost. I'm a health financing specialist, so I'm always interested in making sure that these things are affordable. And I think when Carol was talking about, was speaking, he spoke about the 3 A's, we spoke about 5 A's. I completely align with 3. I mean, I'm not against the other 2, but 3 really speak to me. The accessibility, affordability, and availability. Like, these 3 are so key for anyone to be saying we're making that journey towards UHC. So yes, the preference would be for us to make the investment in R&D in the continent, in the country, so that the medicines are available. But like you rightly said, the issues that lead to stockouts, medicine unavailability, is a whole lot more. And so R&D, having the industry here, is just one tiny parts of solving the problem. We need to unpack the whole thing, and that means going systematically from the very beginning to find out all the factors that contribute to that, and then dealing with that, because that's where we remove the bureaucracies, and then the policies by themselves don't constitute a problem. Thank you.
Right. Thank you so much for great questions, and we're at the end of the discussion. I would like to give each panelist 30 seconds to conclude, touching on, is the future promising? Is the future of supply chain promising? And what is the final remark you would give us today?
Yes, I think the future is promising as long as government has understood that they have to invest in policy, they have to invest in system and structure, they have to invest into human resources to make it happen, right? Funding will always be a challenge, but even if you have funding, you have to make all those investments to make sure that the drugs get to the patient.
Thank you so much.
The future is promising, I think. Even just with the comments that Ines made, she talked about automation and all the work being done. The future looks really very bright, because with the right quality data, with the right system to harness that data and provide information, investment in human resources, because we need to have the right level people working on this, then we can actually make the right steps. In the 2 years that I've been in Rwanda, we've moved from no pricing policy to a point where we actually have one. And I remember that that was one of my pet peeves. When I got here, I kept asking, how do you not have a pricing policy? How do you then procure medicine? So the future is bright, because we're making incremental steps every day towards UHC.
Right. Thank you so much. Thank you so much, panelists, for giving us your time to discuss about this topic. Thank you, audience, for your kind attention and for great questions. Thank you, and I wish you a good evening.